So in this session, we're going to talk about maternal resuscitation. How many of us have ever participated in a maternal resuscitation before? Confidently. Up. Okay. For those of us who've never been in such a situation, we're going to simulate what exactly happens in this situation. And since we have two candidates, Jane and, sorry, what's your name? Pardon? Mboro, who've previously participated in a maternal cardiac arrest, then they will help guide the discussion in this session. Okay. So don't worry, we are here to learn from each other, we are here to guide each other, so you won't feel like you've been thrown into the deep end. All right. So everybody has their casualty up or their algorithms for this year. So on page 3, you'll find your maternal cardiac arrest resuscitation. Okay. So for these sessions, we have 7. Try to make it as simple as possible. Learning objectives. Number 1 is that your BLS response for your maternal patient is similar to an adult cardiac resuscitation. Is that okay? What I mean is you will assess the scene, you will ensure safety first, you will scream for help, you will go ahead and try and stimulate your patient, you will check for a pulse. Are we clear? That is the same across the board. That doesn't change. Okay. Second objective, you will treat your mother just like an adult cardiac arrest. Meaning, are you going to give adrenaline to your patient? How many say yes? How many say no? Bro, what do you say? You give adrenaline. Okay. So, in the event that you want to use this beautiful machine over here called a defibrillator, are we going to shock our pregnant mother who's gone into an arrest? If it's a shockable rhythm, you're going to shock. Okay. If it's a shockable rhythm, I am not going to shock. You look a bit conflicted. So we're still going to shock our patient. Is that okay? So those protocols do not change. The cycle of resuscitation is still 30 chest compressions with every 2 ventilation breaths. You still give your adrenaline after every 3 to 4 minutes. Shock if it is a shockable rhythm. Yes, in Raisi? Good. Yeah. Number 3, you will start an IV access. But in this case, you want to be above the diaphragm. So we have our mother and she's lying flat. Where is her diaphragm? Huku. Sindio? So if you're going to start an IV line, where do you think is the most appropriate place to place an IV in our mother? There's jugular. Antecubital fossa. So that means we will avoid putting the dorsal areas, the radial veins. So we'll want to target the antecubital fossas. You can target your jugulars. And to even help your matters, you can help also elevate the arms a bit to keep it above the diaphragm. Is that okay? In the event that your mother went into a cardiac arrest while getting magnesium sulfate, you stop the magnesium sulfate. Are we clear? Yeah. Why?
It's a sign of toxicity.
It's a sign of toxicity. Okay, what will you give in its place? What will be the antidote? Calcium gluconate. Good. Okay, so number 4, your patient is still in arrest. You'll want to go ahead and do a manual uterine displacement. Are we clear? What is the reason for this? One person, please. I will give you a chance.
Like the gravid uterus, usually when the mother goes into a cardiac arrest, it compresses the blood vessels from the heart. So by manually displacing it, it prevents obstructing blood flow, which is really important because of the filters the mother wants.
Okay, very good. Did we get that explanation? Okay. So do we displace all gravid uteruses? They're all gravid, even at 1 week, it's a gravid uterus. They're all gravid, but so when do you start thinking about displacing that uterus? Third trimester, you're talking about how many weeks here? 28 weeks.
I'm thinking anything above the umbilicus.
Anything above the umbilicus? Okay. Anyone else? Okay. So simply put, you would not displace the gravid uterus that is around the umbilicus. Is that so? Or just slightly above the pelvic brim. It makes no sense because it's not compressing any vessels. Again, if you have late 2nd trimester, early 3rd trimester, then you would want to start considering displacing that uterus. Is that okay? That's a clear, a helpful guide. Okay. Number 5, time. Time. Time is of the utmost importance. Remember here you're dealing with 2 patients. It's just that one is internal, but there are 2 patients. Are we clear? So in order to save both lives, you have to really work very fast on the one that you can actually see and touch and do your interventions on. During your resuscitation cycles, you go into resuscitation teams. There's usually a time keeper, there's a team leader, there's one who's on IV medication, there's one who's particularly dealing with circulation and chest compressions, isn't that so? And there's someone else who's dealing with airway. So the person who is on timekeeping, your timekeeper has to be very sober. Immediately your mother goes into an arrest. That is your time 0. So like right now, I think it's around 2:30, 3 p.m. So 3:15, that's our time 0. Is that okay? Because the reason why we are talking about time is that the moment this mother goes into an arrest, do you think the fetus is getting any circulation? No. So if we do not intervene fast, we will lose 2 patients. Is that okay? So time is of the utmost importance. And in this case, in maternal resuscitation, there are 2 times where you want to be really keen on. So at 4 minutes, so you've started your resuscitation, a cycle lasts 2 minutes. Your second cycle, that's 4 minutes. And your timekeeper has to be very vigilant and shout it out. 4 minutes are up. And even prompt. If you see you're moving, nowhere. It's like, is there anything else you think we can do for this patient? At the 4th minute mark, and you've still not achieved ROSC, that is return of spontaneous circulation, you need to start thinking about getting the baby out. Are we clear? Minute 5. So within 5 minutes, that baby should be out. Why? What is the logic of going ahead and performing an emergency C-section? and removing that baby. Yes, Dr. Adams.
It's your chances of saving the mother are low and now getting lower, so you're doing what you call a perinatal delivery for that child. Because after that time, the baby will not do that. So I think it's a choice of recognizing mass.
Okay. Good attempt. Good attempt, Adams. Anyone else? Yes? Piano?
It's possible the time, how long does it take for the brain to lose, the baby's brain to, the duration of hypoxia for the child?
For a child would be less than 3 minutes. So here we are talking about 4 to 5. Uh-huh.
I think is to relieve their depression. It's about the mother now.
Mm-hmm.
The autocare will
Very good. Yes? Mm-hmm. Very good attempt. There's something that Aspo is trying to say. Louder. Louder, please.
So it's about the mother here. You want to relieve the autocable compression by that gravid uterus. So you have just to get the baby out so that you can also save the mother.
Remember, you're working as a team. When someone else is doing chest compressions, there's someone who is still here doing the lateral uterine displacement. And to effectively remove that load from the vessels is through an emergency C-section, so that we can ensure venous return, so that all that blood that was pooling around there can come back to the heart, so that you're no longer pressing on an empty tank. There is something to push out and circulate. Are we clear? Okay. Number 6, this was the prepare team. So your team should have at least an obs-gyne. If you're not able to get an obs-gyne, an EMO, because EMOs are certified to do C-sections. Get a pediatrician. You can get your midwife, anyone who's certified in also doing neonatal resuscitation. Because at this point, once that happens, there will be one resuscitation team on that end, and this resuscitation still needs to continue. Are we clear? Number 7, during your resuscitation, you want to think about the possible causes that made your mother go into cardiac arrest in the first place. So we've heard about H's and T's before. Is that? We've heard about H's and T's? Good. Before. Who's never heard about it? So Lugudi, that is your assignment for tonight. So tomorrow I will look for you and we'll discuss about the H's and T's. Is that okay? Because that's not our session for today. So potential etiologies for maternal cardiac arrest. So an easy way to think about it is ABCs. A, is it your anesthesia? Because your mother can go into an arrest during a C-section on the table. They're perfectly healthy. But is it the anesthesia that you gave that made your mother go into cardiac arrest? Is that okay? B, bleeding. Did your mother come in bleeding? Antepartum hemorrhages. Did they go into DIC? Is that the reason why our mother is going into an arrest? And you try and sort that out. Is that okay? C, any cardiac issues. It could be heart failure. It could be an MI. So you sort that MI. Are we clear? D, drugs. Is your mother overdosed on anything? Just because a mother is pregnant does not mean they cannot indulge in drugs and alcohol. Is that okay? We advise against it, but it can happen. Are we clear? E, we're talking about an embolism. And the one that we're worried mostly about is a pulmonary embolism. Good. F, we're talking about fevers, sepsis. We had a very heated debate here about sepsis. It was very interesting. Okay, so G, we are talking about other non-gynecological complications. That's the H's and T's. Are we clear? Okay. So I would like us to do a dry run on an actual case of maternal resuscitation. Who would like to lead the case? Mburu? The people have spoken. The tribe has spoken. Uh-huh. Who else would you want on your team? Lorna. Identify yourself, Lorna. Please step forward. Yes. Pick your team. Pick your team quickly. Michael. Remember your team, considering this is a complicated case, you want as many hands on as possible. You don't want to get... Let's see your tag. Yeah, so Tabitha on board. Who else? Michael, Tabitha. Let's see your name. Frederick.
So you want to... I need like 2 more.
2 more.
Yes. Have the guy from Phoenix.
The gentleman from Phoenix. Benedict. Where is Jane? We'll have you on board. Who else? Yes.
Yeah.
Hey, sir. Nani? Okay.
So then I'll be assigning roles.
Yes, assign your roles. Who do you want where?
So Lorna can be on the airway. When we're doing chest compressions, I need Benedict to do cannulation and do circulation. Should be our timekeeper. Yes. Then William will help us displace the uterus. Then chest compressions, timekeeper, circulation. He'll help with the chest compression.
Okay, good.
Right. Then
Okay.
have the gainer, Dr. Adams.
So Dr. Adams is on call as our guy. Okay, he's our obs for today. I hope his phone is on. Okay. Very good pick. Very good pick. Okay. A pediatrician. Mola will be a pediatrician. Okay.
So I think that's the team.
That's the team.
Yeah.
Good enough. Okay, so the rest of us, let's gather around and learn from this scenario. Okay. Somboro, you have a 29-year-old female. She's a primigravida. Currently at, sorry, if I say primigravida, we're all on the same, okay. She's a primigravida. She's currently at 32 weeks gestation, brought in by the husband after she had just collapsed. So how would you like to proceed from there?
So we have a 29-year-old female who is a primigravida at 32 weeks. Has been brought in by the husband, who's just collapsed. So the first thing is to secure the scene. So make sure the scene is safe.
Good.
Make sure that I'm safe. The next thing is to stimulate. Okay, so we assess for responsiveness for this patient. So I don't know the name, so... Okay, Jane. Hello, Jane. Jane, is she responding?
There's no response to touch.
There's no response. If there's no response, then we'll shout for help. Activate with the emergency system, so I'll call the resuscitation team. Then we have a lady who's collapsed and is non-responsive.
Anything else you'd want to do before you call for help?
We're going to check our valves, of course. So we check at the carotid.
So you check a
5 to 10
pulse.
seconds.
There is no
So
pulse.
there's no pulse.
Uh-huh.
Of course, we call the resuscitation team, ask them to come with an emergency trolley. Please inform the gynecologist and the pediatrician.
Okay.
Dr. Adam, I'm on my way.
Okay. So remember, we have no pulse. We're already at time? Time 0.
Time 0. So once I've shouted for help, so I'll come and start chest compressions as my team is here.
So your team has arrived.
Okay, so my team has arrived. So Michael, please start chest compressions. We'll do 30 chest compressions.
Good.
And 2 breaths. Lorna, please give breaths. With BVM. Please open the airway, head to chin lift. Use the EC cloud technique to clear the mask.
Very good.
Please, Benedict, get an IV access. Please to large room. Please, to keep it on
The
four
patient's left. Yes.
Right. So our timekeeper will be started. Right. Please inform me every 2 minutes.
What else would you want to give for your patient?
I want to start on. I want to give adrenaline.
Good. Who's on IV access?
Benedict is on.
Give the instructions to him.
So Benedict, please get an IV access. Please take blood samples. Give adrenaline 1 mg.
You prioritize adrenaline. Pardon? Yes.
So
But remember, you need your patient flat when they're being compressed. So you can't put them on the side completely.
so
Do we have IV access? Has Benedict
Benedict,
conferred the message back to you?
yes. We need to have a closed loop communication, please.
Very important. Benedict, remember we are 10 people on this team. So when you do something silently, the team leader doesn't know. So IV access is good.
All right.
Blood samples taken.
Taking blood samples.
Adrenaline given.
Yes, first dose.
How much?
And so the 1 milligram.
Okay.
So adrenaline given. Thank you. What time do you have?
We have 1 minute and 14 seconds.
So at this time, as they're doing resuscitation, we'll also be connecting the patient to the monitor.
Okay. So you connect the patient to the monitor.
Have been all right. Is it 2 minutes? All right.
2 minutes are over now.
2 minutes are up.
So let's stop chest compressions first. Let's reassess. So we are assessing for pulse, and at the monitor, we're looking at the rhythm. So
On the monitor, it's a flat line.
so we have an assistant. So
And there's
resume
still-
chest compressions. There's the pulse. Is there pulse?
There is no pulse. Good.
So resume chest compressions. We'll give another dose of adrenaline at the 4th minute.
Okay. Anything else you'd want to consider for your patient?
We want to look at the possible causes.
The possible causes.
So we talked about A, which is anesthesia,
Anesthesia. Your patient has not had any anesthesia.
any bleeding,
Any bleeding? No. The husband will be able to tell, but as far as he knows, he's not seen any bleeding.
any cardiac causes, maybe a history of cardiac disease,
No, she's been perfectly healthy.
drugs that she was taking probably.
She ni Mkristo. Akunywangi.
Chini ya maji.
Bibi yangu anapenda Bwana. Aja. Okay.
We are not at the 4th minute. Wait for the timekeeper, please. Timekeeper is telling us the 4th minute.
Anything else? Anatime you what?
Time everything. She's timing everything. So we need to look at their fevers.
Are there fevers? She's feeling a bit febrile.
Then I'll move, probably dealing with sepsis. Don't know. We'll check for our H's and T's. So our H's.
Let's have one discussion, please. One discussion. Because we don't see this a lot. Sindio?
So we took samples, so we're looking for any hypo or hyperkalemia.
So we took samples, our lab reagents hakuna. So tumetuma relatives nje.
Blood gas.
Blood gas, ICU is running the sample.
All right. We check our sugars.
So you check our sugars, our RBS is 2.
Yeah, so we need to give a bolus. So we give 50% dextrose, 50 mils. Give 50 mils of, yeah. So hypoxia, we already given oxygen.
4 minutes are over.
2 minutes are up again.
So 2 minutes are over, we are at our 4th minute. So we check for our pulse
Check for pulse.
and the rhythm on the monitor.
The rhythm on the monitor is a sinus rhythm. However, there is no pulse.
We're dealing with a PEA.
Good.
One, give another dose of adrenaline. Let's resume resuscitation. Resume chest compressions. The guide is here. Please do an emergency cesarean section.
So after
Our neonatologist, be ready to receive the baby.
We are within the 4-minute bracket. What are we expecting to happen?
You need to start taking the baby out.
So who is doing it?
Someone is here.
Where is he? Okay. So remember, Daktari, all these things happen synchronously. Is okay?
Yeah.
Okay. Our patient is falling.
I will do an baby is out.
So that is another team. So we continue. Okay.
So we continue resuscitation.
Good.
Our H's and T's, we have the back.
So potassium is 4.
So that's normal. Our blood sugar, this point is, we've already given a bolus.
We've given a bolus. Our repeat RBS is around 5.
It's 5.
5.
Our BG is back.
BGA is back. We have bicarbs of 26. We have a pH of 7.37.
All right. So in terms of toxicity, you said there are no drugs that you are taking.
There are no drugs that they've consumed, no toxins, they've not been exposed, no history of trauma, none.
History of like prolonged standing, sitting. So 2 minutes are over, let's reassess.
2 minutes are up.
So we reassess for pulse and everything. Can you just for 5 seconds?
the pulse.
Do you have a pulse?
Yes, we do have a pulse. The rhythm, it's a sinus rhythm.
What's the rate? So we have return of spontaneous circulation. Do we have breathing?
No, we don't have spontaneous breathing.
We continue bagging every 1 breath every 5 to 6 seconds.
Good.
So we go for post-resuscitation.
Care.
Cardiac arrest here.
All right. Very good. We are going to end the simulation there. Okay. Points that you've learned from this simulation. Teamwork is very important. Good. Communication is very important. And not just communication. Communication can be somebody put an IV line. You've communicated, but the message has not gotten to your recipient. So it has to be a closed loop communication. Is that okay? So teamwork, closed loop communication. Number 3, time. Time is very important. Had we not intervened during the 4th minute, we would have lost both the mother and the baby. Is that okay? Number 4. Take home points.
The hitches.
Are there possible downloads?
How fast?
It depends.
In the depend, not always. Remember when we are asking for someone to do, just a minute. Remember when we are asking for someone to do the emergency C-section, it doesn't have to be an OBS. As long as you have an MO on the floor. Your MO could be in IMED, in PEDS, in surgery. But they all got certified to do CSs. Get your MO. Is that okay? If it is out of your scope of practice. Because your OBS guy could be very far away, or they could be in theater with another patient. Isn't that so? Yes. Good. So take home, number 4. What else have we learned today? Preparedness. If Mburu was not prepared to handle this case, if Mburu did not prepare a proper team, we would not have saved this mother today. It would have been a sad day. Cynthia, so kudos to you, Mburu. Kudos to you.
And team.
And the team.
I was staying here.
And the team. My apologies. Kudos to Mburu and the team. Everybody conducted their roles well and in a timely fashion.
Something else, during preparation, it's always good to have SOPs so that you can have what you're supposed to do, not just like you have a protocol, you have standard operating procedure, you don't get confused.
Very beautifully said, and that is why we have an algorithm that you have in your casualty app and in your hard copy algorithms, the book. So when you go to page 3 of that book, it will outline for you how to properly conduct the resuscitation. Is that okay? Yeah. So those are that becomes your guiding light, your SOPs, if I may say.
And then conduct regular trainings in your departments. Just like the way do normal CMEs, say this one we are practicing maternal resuscitation. 30 minutes, you're done. So that when now it happens, everyone knows what to do, they move quickly.
Okay. Take home number 6. Number 6, yes. William, what did you take home today? It's all right. Take home number 6.
Look for the possible causes of cardiac arrest.
Always look for the possible causes of cardiac arrest. Did you remember what Mboro was asking? Was your patient exposed to anesthesia? No. Was your patient bleeding prior to this? The husband said no. But remember bleeding, there's a possibility of concealed bleeding. Sasawa. So it's possible they weren't bleeding physically, but you can have a concealed bleeding that you're unaware about. C, did your patient have any previous medical history? None. No cardiac arrest, no heart failures. They are not intoxicated, they don't take alcohol, they've not come into contact with anything that is poisonous. He went through it through a systematic manner. And you get all that information during history. Ama? Simple questions. Sasawa. A, B, C, D, E, F, G. Plus H's and T's. And you can be able to pinpoint what the problem is with your patient. The reason why our patient achieved ROSC is because Mboro correctly went through the probable causes, the H's and T's, and the probable maternal causes of cardiac arrest. And there was no factor. He checked them out. There was hypoglycemia, which he corrected. During the next cycle, our patient achieved ROSC. Is that okay? Any take home number 7?
A question.
Yes.
Can preeclampsia lead to cardiac arrest?
Absolutely.
So we also need to ask whether there is any pre-existing condition.
Yes, you need to take a history of any pre-existing conditions. Yes. Okay. Yes?
If this mother has a cardiac arrest in a hospital that cannot access her gynae, what do we do?
Is there an MO?
Or like a health center?
Health centers. Pardon?
In a hospital that cannot operate, there's no MO.
There is no MO anywhere. So in such a setup, I know our resources are limited and sometimes they can be overstretched. So in a case whereby you don't have an MO in your facility, you continue with your resuscitation, call ahead of time for a referral place. Is that okay? And remember, document, 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 document. Is that okay? Don't go outside your scope of practice. Yes.
To remember on that, maybe they should always displace the uterus.
Thank you very much, William.
I also saw she was asking for the people to take.
Mm-hmm.
You can use that in place of her pushing, pulling down.
But a bit. Remember, you want to also give your effective chest compressions. So your mother will be titled in such a position. You might not be able to compress the chest adequately. So the best thing that we advise for is for the lateral displacement. And that is now within the 4 minutes, 5-minute mark, you want to get that baby out as soon as possible. Any other question?
I think probably would you consider that if you're short-staffed and you don't have enough personnel?
Mm-hmm.
You don't have somebody to be tinting for you. You probably just have someone on the airway and the chest. So would you just put up people so that to be able to
assist in that situation, if you're short-staffed, you can. But again, remember, you want to get the best results possible. It's the same way we emphasize on effective chest compressions. Don't do shallow compressions just for the sake of doing it, but do it to make an impact. Is that okay? Oh, same question. Okay. Any other question? So we'll be comfortable with maternal cardiac arrest resuscitations. We won't run away. Ukisikia sister meitana, woo! I have a mother who's collapsed. Please don't run away. And as Pauline had said, you want to keep on doing these simulations in your stations. So the more you pass this knowledge to someone else, the more that knowledge sticks with you. And the more comfortable your team becomes. There's nothing as bad as an emergency dropping and everybody is panicking. Yes. Okay.